Hit record. We're ready.
All right, wonderful. Hi, everybody. I am Kristen Hood-Watson, and I'm going to be presenting the second webinar in the Clinical Faculty Development 101 series, and we'll be talking about creating a curriculum. So just kind of as a way of kind of administrative business, just so you know, this is designated as one AMA PRA Category 1 credit. And though this falls under an exception where we do not have to disclose relevant financial relationships, should we have disclosed, I have nothing to share. And for those of you who were not able to attend the first webinar of the series, the goal is to provide faculty development for those interested in medical education, whether they're other students, residents, faculty, community preceptors. And this will take place over 3 years, and there will be 9 webinars a year. It shows you the month we will not be holding them just due to those being historically busy in academia. Again, we talked about CME credit per webinar attended, and typically they will be on the second Thursday of the month at 1 p.m. And of course are based on the guidebook for clerkship directors. So you can see here the 101 series that has started last month and will go through June 2022, really laying the foundation of medical education. And then the 201 series ending in 2023, and the final 301 sessions, which again continues to go more in depth and will go from 2023 to June 2024. So again, this particular talk is based on chapter 7 of the guidebook for clerkship directors, the most recent edition, which is the 5th edition. That chapter was written by myself and Dr. Alec Chessman. So what are our goals for today? What I would really love for you to take away from this are how to create curriculum goals. So what are the objectives that you're trying to achieve and how to set those objectives? Also then thinking about what are the educational activities that you will use to achieve those goals. And then finally, figuring out how to evaluate your curriculum and continue to enhance it. So just to get to know you, if you wouldn't mind typing your name, institution, role at the institution, and number of years in that role in the chat. This also helps with tracking CME credit. Again, I'm Kristen Hood-Watson. I'm at the Medical University of South Carolina in Charleston, South Carolina, and I'm the Director of Medical Education and also the Family Medicine Clerkship Director, and I have been the Clerkship Director for 8 years. And then as we're going through this session, feel free to now or later put in what are some of the big curricular challenges you've experienced or as a clerkship director or clerkship faculty. And again, also feel free to add any questions that you may have. My goal is going to be to try to get through the entire presentation just so I can make sure we cover the content and then answer any questions you might have at the end. Okay, so where to start? So I recognize that we all may be coming from very different places, meaning we could be clerkship directors, clerkship faculty. We may be, have done this for a little bit, maybe be a little more seasoned, or maybe someone who's transitioning into the clerkship director role. Perhaps you're brand new faculty and taking on this role. So really trying to, navigate a range of challenges. So keep in mind, as we talk through this, the goal is that you'll take this and try to manipulate it into a way that fits your scenario. And again, we can also talk about that later if there are any particular questions that anyone has about how to do that. And my other kind of starting piece of advice for anyone who is newly participating in medical education or is a clerkship director is if you are able, you have a clerkship that's already been built for you. If you're able to take a year or even, 6 months and really see the flow of the curriculum, and then really go from there to think about like, what are the challenges? What should we change? Maybe what's already going really well. So with all that being said, the first thing I really would encourage you to do is to join your specialty's educational organization. I will say that this has been one of the most helpful things that I've done in my development as a clerkship director. I was also very fortunate in that Alec Chessman, who again co-wrote this with me, was a family medicine clerkship director for about 20 years before I took over, and so was an excellent mentor. But he actually really plugged me into our organization, Society of Teachers of Family Medicine. And from there, I was able to utilize their national clerkship curriculum that was already established to make sure that we were in line with that. I joined collaboratives where, we could just send online, messages to say, hey, I came across this difficulty, or I have this question. Could anyone give me their perspective? And so you have this national group of clerkship directors or faculty who have some idea of what you're going through and can provide their knowledge. So it was really beneficial. And probably the most important thing I did within our organization was to attend the conferences. So of course now, as with this, things are virtual, but it really allowed, for two important things. One was just going to the sessions. And I can remember one of the most helpful sessions as a brand new faculty member was talking about remediation, challenging learners. And there was just a lot of input, a lot of energy in the room. And so it was really helpful. Also from there, just really collaborating with other faculty across the country and trying to, continue to innovate within our field. So again, definitely would recommend starting there as your foundation. And here are just the organizations that tend to provide that information. So giving the content, again, that they think is core to your specialty, and also just as a general guide for clerkship directors to say like, hey, these are things that you should be thinking about in our particular specialty. As you can see, some of the fields have two organizations that work together. For example, pediatrics has APA and COMCEP, which work together. And just as an FYI, if you haven't already utilized these resources, some of them you can just Google, and I've actually looked through various ones. Some you have to become a member and would have to log in. And then others, such as the internal medicine guidelines, you can purchase on Amazon. But again, would definitely recommend this as a great starting place. So after you have your specialty specific goals, and you know what are the national standards, what you need to be thinking about, trying to figure out what are your institutional goals. So one of the first things I did when I took over as clerkship director was to meet with our associate dean for clinical education and really just got her perspective on where our clerkship was, where were the areas for improvement. And I didn't realize how helpful it was at the time. I just thought this was a meeting I was having, but she really, in her role had really great knowledge and insight into, what we could improve upon. And on top of that, working together as an institution, so working with our all the clerkship directors coming together. So we have a committee called CSPEC, or Clinical Science Planning and Evaluation Committee, and we meet monthly. And so, kind of checking in as to what we were all doing and making sure that we were aligning our goals and objectives. So, for example, we have, as I'm sure most people do, we have a procedure and diagnosis log. And in our procedures, I realized in year 1 or 2 that several of us were doing a suturing workshop. So that was part of our initial kind of orientation up front, like here are some key skills as a family medicine or for family medicine that you'll take into the rotation. But OBGYN and surgery were also doing suturing workshops. So we said, you know what, there are other things that we think would be really important to incorporate, and probably all 3 of us don't need to be doing a suturing workshop. Or talking about what diagnoses are being covered. So in our overarching curriculum committee, for us, that's called the undergraduate curriculum committee, the pre-clerkship faculty said, hey, we teach a lot about type 1 diabetes in year 1. And so where is that being covered in the clerkship? And so they looked through all of the procedure and diagnosis logs for all the clerkships, and it wasn't something that was being routinely covered as a mandatory diagnosis. And so what we decided to do was, rather than just add it on, was to really, from a clinical perspective, think about like, what is the likelihood that a student is going to encounter type 1 diabetes during the rotation? And should it be a mandatory diagnosis? And so we actually just piloted it for a year, and family medicine put it on our diagnosis log, and internal medicine did as well, because thinking that, in the hospital, we see a lot of DKA. And so maybe that's where it might be better served. So again, just taking that knowledge and making sure that our curriculum, throughout the 4 years is really covering everything we want to. And then another thing that we, to think about are what settings are your students in? So for us, and maybe a lot of other schools, there's a lot of inpatient work for the 3rd year. Family medicine, of course, is the exception where it's predominantly outpatient, but we realized students really needed more ambulatory experience. And so other clerkships really worked to continue to build that part of the rotation. And keeping in mind that besides these things that you may just discuss in your curriculum committees, there are also LCME visits where you're doing, self-study year, really looking at areas for growth. There may be the feedback after you actually have the LCME visit. There are, all types of ways where these institutional goals may come about. So next, departmental resources. And this may be one of the most important things to think about. What are what are the resources that you actually have available to you? So again, thinking about some of our schools only have 4-week clerkships. I remember at my medical school, our internal medicine clerkship and surgery were 12 weeks. So where do you fall in there? And if you are a 4-week clerkship, how do you cover all of the content that you might have? So recognizing that you might have to kind of really rethink that. Or what about if you are at a school that is not associated with like a big academic medical center where you're going to have residents available? Maybe you have to send your students out into the community, and you might be working with a variety of institutions. So again, I want you to take this into account. I understand it's going to be different for each clerkship and each school. So thinking about the strengths of your department, for us, when I first joined, we had a faculty member who was just amazing at teaching EKGs. And so much so that I remember being in a meeting with some of our students, and they told one of our deans that this person provided the best EKG teaching that they'd ever had. And, of course, being very proud of that. And then that person, a couple years in, decided to step away from that role. And so we really had to think about, okay, is there someone who's as knowledgeable and passionate about EKG teaching so that the quality of the rotation or of that workshop would be preserved? And for us, what we ended up realizing is that probably not, that probably was not the case, but that there was other content that was really important, particularly for us focusing on social determinants of health. And we had 2 brand new faculty who both had masters in public health, and it was a passion of theirs, and worked very, very diligently to care for the underserved. So we, our strengths changed and we adapted to suit that. Also thinking about what is the time and funding allocated for teaching in clerkships? So obviously clerkship directors receive time, and a lot of that is really for the administrative part, maybe not as much for the teaching. And we still have clinical responsibilities, and we get varying amounts as clerkship directors of time. And so who's going to give those didactics? Who's going to host those workshops for the rotation? And that, I know, having attended a lot of conferences, I know that is tricky for a lot of people. You really have to incentivize teaching, because if you're not in a clinical space, then you're not making money. And so we have to make sure that we really preserve the value of teaching and have the department and the institution recognize that value. Thinking about that, again, for those of you who are at an academic institution where there are residents, are you using residents as teachers? I will say that our students love our residents. I mean, absolutely love them. And we enjoy having them with us. And so they not only are precepting them in clinic before checking out to the faculty, but they are also coming and helping with our workshops, giving feedback on standardized patient encounters, and they are just a huge resource. So definitely would recommend that. We are lucky in that we actually have something called an academic track. And in that track, these are residents, of course, who are already passionate about teaching, but we even get resident volunteers who are not in that specific path. So something again to think about. And then, are there already resident didactics included in your department? And again, I know this is only pertinent to those of us who are at an institution where we have residents, but if there are workshops, lectures that are not too far above a medical student level, I would absolutely encourage you to include students in that. And for two reasons. One is you're getting the most bang for your buck. So you're teaching the residents, teaching the students, and you have that faculty member's time already available. The second is our students love being with the residents. They love being around them and getting their perspectives. So another benefit to utilizing resident didactics. Again, if it's over their head, students do not like that and certainly wouldn't recommend that, but something to consider, maybe just kind of picking and choosing. And then what are your challenges? Again, as I mentioned, I know some of us have shorter clerkships and it's hard to fit everything in. For us, coordinator support is so important in general for a clerkship, but also is important for our curriculum because they make things happen smoothly. So we have a lot of virtual learning that happens because we're a distributed clerkship, meaning our students go to sites all throughout the state. And so it takes a lot for our coordinators to make sure that the students have the lessons, the module access that they need, and then have the information that they need to then follow up with us in our small group sessions. And so, just a big shout out to having amazing coordinators, which I'm very fortunate that we do, but something else to kind of consider and think about. So moving on to actually creating objectives. So the first thing, of course, you want to do, I think we're probably all familiar with Bloom's taxonomy, but you want to think about what is the level of education of the learner. And, certainly we don't want to be going through remembering and just general understanding or those lower level thinking skills as a third year student. We really want to be moving more towards analyzing, certainly application, but they probably even do that earlier on too, and kind of analyzing and really creating plans for patients and using those nuances to make decisions in clinical care. And I should also mention before moving on that another really great resource that I'll talk about in a few minutes that as you're thinking about creating objectives are using the entrustable professional activities to think about that as a potential way to decide what you would like to achieve in a clerkship. And then also the AAMC's Physician Competency Reference Set, or PCRS. That's another important way to think about, okay, these are the things that are considered competencies or entrustable professional activities. How are we doing in moving students along those activities or competencies? And that should be part of how you create your objectives. So again, thinking about an example, this particularly for type 2 diabetes. So in pre-clerkship, an example of an objective may be simply identifying first and second line medications in the treatment of type 2 diabetes. But by third year, you certainly want them to be moving past and again, analyzing. So you want them to implement a management plan for someone with type 2 diabetes. And what that means and how that is different is what you're thinking here. All right, I have a patient who has type 2 diabetes. They also have chronic kidney disease. They're at CKD stage 4. And so I know that with their current GFR, that they probably, it's not recommended that they're started on metformin, which is considered first line as a medication. And also SGLT2s, probably not a good next step. But GLP-1 receptor agonists, that's okay in someone with their glomerular filtration rate. So kind of keeping that in mind as they're making decisions. So again, they're manipulating in a positive way the information that they have and taking the whole patient into account. So you really want to make sure in the clerkship level that you're moving students on to that level of again, not just understanding, but analyzing, applying. So we're going to kind of talk about this in two ways. So now that we have an idea of how to create objectives, where to go to start, talking with your educational organization, your institution, your department, and kind of really narrowing things down. How do we achieve those goals? And so the first way we're going to talk about it is by instructional method. So you may say, I just want to assess someone's knowledge, or I want to provide knowledge. Or you may have, clinical experience, procedural skills. How do you make sure that you're taking into account professionalism and ethics? And the instruction are the various ways that you can do that. And certainly there are lots of different ideas, but thinking about knowledge. So just imparting knowledge, lectures, patient care. We always tell our students that is the number one way that we think they should be learning, because that tends to stick with them more. Journal clubs, but then looking at, clinical encounters, the actual doing. So of course, again, patient care is number one. Using objective structured learning experiences, which we call OSLEs. So again, standardized patient scenarios that are predetermined. Simulation centers. So we have SimMan, where we can have cases where the patient's unstable, they could code, and the students actually have to run those scenarios. All the way through QI, so quality improvement, and discussing social determinants of health. So some of this we do in workshop models, some of them we do in quality improvement projects or small groups. But as you can see, there's a large variety of ways that you can try to achieve these particular components. And what I would say is just thinking about what are the chances that something is going to, occur in patient care? If you think that it's unlikely, then go ahead and use one of the other methods. So, set up a workshop or use a simulation scenario to try to achieve the goals that you have. It's certainly not a failure if you're not able to, achieve all of your goals and objectives through patient care. Again, for us in particular, everything on our procedure and diagnosis log is the students are recommended and are very strongly encouraged that it all should be through direct or team-based patient care. However, there are some things that we know are going to be a little bit more difficult to ensure happen in that space. And so, again, our social determinants of health, we have a home visit where the students go in and talk to the patients. We have a whole guideline, a rubric that they use, and they use the Prepare tool, which is a screener, to go through social determinants and then use that information to go back and benefit patient care. And so again, that is a way in patient care, but they're doing it outside of the office, outside of typical clinical inpatient time. So again, get creative. These are important skills, and you want to figure out how to make sure that all learners are achieving them. So I wanted to talk about this in a different way. So let's talk about some of the specific activities and why they could be beneficial. So again, patient care, of course, is the most beneficial because that's how they're actually, getting that hands-on experience. That's the way that knowledge is most likely to stick with them. So, definitely that's important. And like I said, sometimes you might need to try to manipulate in a positive way again, the experiences. So say, for example, interprofessional experiences are part of your procedures that you want a student to take part in. And this is important, right? So interprofessionalism is very important. And yes, our students see how closely the nurses and physicians and PAs and NPs work together, but we want the students to have that same experience. So we may designate that the student works with a PA for a half day to see, are there any differences or what is their perspective? We have them work with our PharmDs in clinic or our phlebotomists. So they really have an opportunity to work closely. So again, sometimes you have to, make specific schedules to try to incorporate different objectives into patient care. The other thing are didactics. So I think one of the more challenging competencies to achieve is, having students recognize errors or flaws in the system and then being able to address them. So while yes, again, these things can happen in patient care, it's harder to really have a good discussion about that. But it is a competency in the physician competency reference set, or PCRS. And so having a lecture where you talk about what this means, and then small groups, to your breakout groups that, talk through a case and figure out how to actually address this. So again, you're really thinking a little bit outside the box, like I want to achieve this goal. but what's the best way, to achieve it so it's meaningful and actually going to occur? Similarly, workshops. So for us, we have a theme throughout our clerkships of managing unstable patients. And I think we all know that students are likely to see an unstable patient throughout their time as a medical student in their clerkship years. But certainly the scenarios are different. And oftentimes, for us in our inpatient setting, we have a MET team. So that's the level before the code team. We have all these different teams who come in when these unstable patient encounters occur in real life. And so the student is likely kind of in the background, and while watching is helpful, we really want to move them to the next level of participating. And so what we do is use our simulation center, our SimMan. We have cases developed, and we really allow the students to interview the patient, examine the patient, because the patient will have different heart sounds. You can change their pulses, you can change their are they wheezing, or all these types of things we can change, and we let them manage the patient. And it gives them the opportunity to identify emergent and urgent care and really take part in unstable scenarios and see how their management plans affect the patient. And it also is a really great team building experience. So again, if you have access to a simulation center, this is just really helpful, and students love it. They love having that hands-on experience. So lastly, independent study, again, as part of the competencies from the physician competency reference set through AAMC, it is expected that students are able to evaluate, locate, evaluate, and appraise scientific evidence or articles. And so hopefully that happens, again, some in patient care where they're learning about something new, they go and read about it and then come back and present it to you. But you may have to create an additional kind of experience or requirement for your course where there is some independent study time. And that's okay too. So again, some considerations, as I've mentioned throughout, like what are your resources? Do you have a simulation center where you can set this up? Do you have access to standardized patients, which are paid, I guess actors we'll call them, who are trained to give content that you have created? And if you do, that's fantastic. But if you don't, certainly trying to be creative. I know some smaller schools actually use faculty to kind of be the standardized patients, or again, residents. And then thinking about what is the likelihood of an activity being completed. So I mentioned early on in the beginning that when our pre-clerkship colleagues wanted us to include type 1 diabetes, those in the clinical realm were like, I don't know what the chances are that everyone sees this in this rotation, but let's look into it. So before you make, just jump to a decision or jump to making something mandatory, absolutely think about how you will, or maybe not how you will, but if you should implement it. So do a little research, do a little investigation, a pilot before you make those types of decisions. And then another thing, this is a little bit off topic, but something that I found to be really helpful is thinking about the why. So why are you requiring certain activities to be completed? And similarly, why not? And what I've learned is this is really important to student satisfaction. So having some context makes a big difference. And so much so that what we do now is actually in orientation, we'll say to our students, so we do this because, or what we have learned from quality improvement or just years of kind of practice, this seems to be really effective for students and really helps them in, whether that's taking the NBME exam or feeling really competent and in different skills, like this seems to be really beneficial. So providing that could be very, very helpful to students. So I would definitely recommend that. And then of course, it's also important to your governing bodies. So whether that's your curriculum committee or, obviously for LCME, you want to be able to say your why are you doing these things? And then lastly, for the educational activities, thinking about alternative mechanisms. So as we all know, these are required. So And this has become really important in the past couple of years. So with a COVID impacted curriculum, I think especially in March of 2020, we had to be really creative. So I will say, again, for our PXDX log, our procedures and diagnosis log, we always had alternative mechanisms. And as I mentioned earlier, we were very clear with students that we expected them to achieve these 100% through patient or team-based care, that they, if absolutely necessary, there was a small percentage that could be through these alternative mechanisms. And for us, we, again, were fortunate because we have the Aquifer family medicine cases, which are very much in line with the clerkship curriculum. And so pretty much everything, at least on our procedure log, on our diagnosis log, was covered in an Aquifer case. So that was one of our alternative mechanisms. We also had standardized encounters, right? So again, having those standardized patients, having scenarios that we could easily implement if something wasn't able to be achieved in direct patient care. And then, as I mentioned, in COVID times, I mean, we had to get really creative and we stopped doing our home visit. Social determinants of health were no less important and maybe even more important, we realized during that time. And so, while technically, we could have still had students do virtual visits, which is kind of where we're at now, a hybrid of virtual and home visits, but mostly virtual given our recent COVID spike. At that time, though, they were really pulled from all clinical activities. They weren't having the time to interact with patients so that they could meet someone to do the home visit with. And so what we did was look up an amazing online tool where it actually walked students through what it was like to have to make decisions when you had a lot of financial strain or, had other life circumstances that came about. And the students loved it. They really learned a lot from it. And of course, we had them do a little self-reflection that was submitted to us so we could, make sure that it had been completed and see what their thoughts were. But it was a great alternative mechanism. And I think if anything, COVID has taught us how to be very flexible. But again, even before that, being in South Carolina, hurricane evacuations were pretty common for a while. And so this became really important for us to really have quality alternative mechanisms. So another kind of thought, how do we pull this all together? So we have our objectives, we have our educational activities. We've talked a lot about those being competent or being able to meet in trustable professional activities. How do we pull this all together so that we can track it and make sure that we're doing all of the things that we intend to do? And so curriculum mapping is really key to that. I will say that, a couple of years into being a clerkship director, we had to input all of our curriculum map, and it was quite a task. But it really does make you, think very critically about what you're doing and how you achieve your goals. So here's an example of a curriculum map. So you may have an overarching objective, and I'm using our anti-racism curriculum, which we implemented last year, as kind of as an example. And so our overarching objective when we decided to create the curriculum was that we were actively taking a stance against racism and also wanting to use that to mitigate health disparities. So then we convened a committee of our clerkship directors, other faculty who were deemed stakeholders, our residents, our students, and each clerkship created an activity. So for family medicine, we created anti-racism modules and then had small groups as follow-up. The objective of our specific activity was to identify disparities in preventive services, and then also use the implicit mnemonic to help further mitigate disparities in clinical practice. And so this maps to that physician competency reference set, the specific competency of demonstrating sensitivity, responsiveness to a diverse population. And it also could have mapped to some others, but this one was probably the most fitting. So you can similarly do curriculum mapping to include assessments. We did actually later do this and have assessment mapping. And this was also helpful to think about making sure that throughout the curriculum, we were not just saying, you've done this thing, but have we assessed it in some way? And it's not only beneficial to do within a year. So as I mentioned, we found out that there were some things that we were duplicating that maybe we did not need to, but it's also really helpful for the entire curriculum. And so again, one particular example was looking at how we were teaching social determinants of health in the pre-clerkship and where we needed to kind of increase that knowledge for the students so that when they came into the clerkship, they had a better understanding and were able to better care for patients. Again, very helpful, and it can be a lot, and there are certainly some challenges to it, which are that when you're searching a curriculum map, there are some things that are standardized, so we have mapping to specific PCRS competencies or our specific learning objectives for our institution, but then maybe certain words when you're searching through are not there, and so it can be a little bit tricky to navigate, but working with your peers makes it much more helpful because we know our content so well that we're able to say, oh yes, no, we are doing that, and this is what we labeled it. But definitely utilize that curriculum map. So last, as far as the specifics of a curriculum, and this is of course covered later in much more detail in another session, but assessment. So thinking about how you want to assess your learners, and besides what I have listed here, is it formative feedback? Is it summative feedback? So again, formative feedback meaning you're just trying to help them grow. So you're saying, hey, here are the areas you're doing well. Here are areas for improvement, and helping them move forward so that when they get to the summative assessment or kind of that final overall evaluation that leads to their grade, they are, they have that baseline knowledge of what they need to work on to do as well as they can. So again, thinking about that separately, how would you assess knowledge? How would you assess practical skills? So I think for most of us, knowledge would be our NBME exam, our shelf exam, whichever end of rotation exam you use. Also case discussions or general patient care. When a student's coming up with their assessment and plan, you have a good idea of what their knowledge base is. And then practical skills. So again, all procedures, and I mean this in two ways. So procedures, of course, meaning, say a joint injection or suturing have to be directly observed by a supervisor. And so you can actually watch these things happen. You have them log their clinical encounters. And then again, you can have simulated exercises for those things that you don't think students will have a chance to do in direct patient care. So now that we've talked about all of that and we know how to create those objectives, implement educational activities, have your alternative mechanisms, and then we've talked briefly about assessment, let's talk about something that's really important, which is how to continue to revamp your curriculum. And this is something that we are doing constantly, really. And so earlier on, I mentioned really taking the time to think about your curriculum, how it's going, and if you're able, take 6 months to see what are the things that students like, what are the things they don't like, or what are the things that you don't think fit before making changes. So certainly give it a little time unless there is something urgent or glaring that really needs to be addressed. So of course, first is feedback, getting student feedback, and I will say, you can get it in a number of ways. So of course, those end of rotation evaluations that are done anonymously, you get it from the graduate questionnaire data that students complete, a year or more after completing the clerkship. But I will say that the informal methods tend to be the space where we get the most valuable feedback, and that can be positive or negative. And so we implemented several years ago a feedback session at the end of the rotation, and some students will share things in front of the whole group, but then oftentimes someone will hang out afterwards. And again, sometimes it's really positive, like saying, I worked with this new clerkship preceptor and she was amazing, and these are all the things I got to do, or hey, I had this concern. So I definitely would recommend having an informal space to give feedback if possible. Of course, faculty members, oversight committees, and program directors. So when that program director intern survey goes out where they're saying, hey, what are the skills that your interns that came from your school are doing really well at, or like what areas do they need to improve on? great space to get that feedback and then make changes. Similarly, things change in medical education. So sometimes you really just have to be innovative or think about how you incorporate new ideas. So during my time, we had those major changes to clinical documentation where students went from only being able to say, oh, here's their social history, past medical history, et cetera, to their note being important and actually being utilized in the medical record. And, that was huge for the students. They loved it. They felt like they were an important part of the team. It led to faculty giving better feedback, right? Because if it wasn't just a note that was in the chart, just kind of sitting there, but was one that was actually being utilized and edited by the faculty member, it improved that feedback to the students. So thinking about how you might change your requirements for documentation, saying you complete this many notes per half day, or you make sure that you've completed 2 discharge summaries, whatever that might be, just making sure to incorporate those important changes as they come about. And again, significant new content. So of course, anti-racism or health disparities, social determinants of health were always important, and were certainly included in different ways, but with the enhanced kind of vision of this, or really trying to figure out, like, how do we, now that we're all talking about this, how do we make this happen in a meaningful way? This was something that, again, we had a committee for and worked together as a group of clerkship directors. All the clerkship directors worked together to make this happen. So then again, just thinking about that PDSA cycle, the Plan, Do, Study, Act. So generally, it's a pretty quick thing that happens once you get through the planning, and that's fine to be quick. And we'll talk about kind of this in a second, but in general, your goal should be to be responsive as a clerkship director rather than being reactive. So if something comes up, and sometimes it's you quickly want to say, like, oh my gosh, I need to change this because one person reacted so negatively, and that is not an uncommon thing because you want people to be happy. But your job really is to think about the larger group of learners that you're teaching, and so to take a second and say, okay, let me go back and look at all of the student evaluations for this block or for this year for that particular lecture or workshop, and then make a decision based on that. Again, there are some things that just absolutely need to be addressed immediately, and that's completely understandable. But in general, really trying to be responsive instead of reactive. Here's a specific example that we went through in our clerkship. So when I took on the clerkship director role, we were using a non-NBME summative assessment as our shelf exam. And so because of challenges with support, technical support of, for the coordinator who, is the person who proctors the exam, support as far as data. So our Office of Assessment and Quality of Improvement had a lot of data with the NBME exams, and we're really trying to make changes to best help our students, all based on what they knew from NBME. And we were the one clerkship who wasn't using NBME. And so it was hard to get that same level of support. So for various reasons, we decided that we were going to make the change to moving to the NBME exam. And we did a lot of research. We took the NBME practice exam ourselves. We went to national conferences and went to workshops about NBME. We talked to people who actually helped to write the NBME exam and informed the content. And so really try to prepare for this change prior to happening, meeting with students, asking them how they studied for this exam so that we could be prepared for our students to be successful. So we implemented the NBME in July, a few years ago now. And that first block, the results came back and a few students failed. And while I know sometimes students fail, we had, prior years, a few students fail per year on our shelf. So became really worried about this. What I realized was that when we made the decision to move to the shelf, it was also the year that we decided that based on NBME data from all the other clerkships, that we were adjusting the pass cut point, and all of the clerkships raised their pass cut point. The issue was that we had no data for family medicine. We didn't know how that would impact us because this was our first year moving into that exam. And so I reached out to our leadership and said, hey, I really want to do what's best for the students. And I think because we didn't have any data prior to this, we should use the traditional method of assessing and then give us a year to kind of figure out how this will play, like how we'll use this information and kind of reassess. Our leadership was very supportive. They agreed. They said, they wanted us to have an active plan of how we were, going to, make changes. But they said, yes, you can use this cut point for the year. My co-clerkship director and I, who had just, I think, joined me that year, really looked into ways to do this. How do we improve scores? And we're able to implement a formative learning assessment, so a formative exam that then that we were able to show through quality improvement actually correlated with their final shelf exam. And so we use this to say, hey, here are the areas that you need to study or you need to focus on. Of course, I need to study everything as usual, but here are your areas of weakness. Make sure you're focusing on these and building this up during the rotation. And then the next year, we found that our students did, or during that year, our students did amazing. And we were able to raise our cut points to the same range. And it was really successful. So, and again, I know I said take time to think about things, but rather than making quick decisions. But again, I felt like in this scenario, it could have a really big impact and required kind of immediate action to think about. So takeaways, definitely utilizing those resources and, those other clerkship directors who maybe are more senior in your institution, even being in different specialties, you have a lot of knowledge that can be shared. My thought is always determine your goals and objectives and work back from that. So once you know what you want to achieve, think about how you will carry out those activities and how you will assess them. And then continuously reevaluate. So some years you might be like, this is really urgent. I need to work on this now. And these are my lower priorities. And if I get to them, great. If not, they'll get pushed a little bit. But always be thinking about what's new and what's important. And then, as I've said earlier, in general, try to be responsive instead of reactive in making changes to your curriculum. And that's everything I have. Thank you guys so much. I am going to stop sharing so that I can see you, but here's my contact information. Okay, so let me see here. Pull up the chat, see if there are any questions. Oh, sorry, Gary, go ahead.
I was going to say there's one from Xiaomei Song that asked about, do you map each didactic or workshop learning objectives?
Yes, we do. So that has been something that has been important. So each learning activity we do map specifically. So at one point we used all of the Aquifer family medicine cases in our rotation as a way to study. We mandated them. We mandated the students do all of them. And we had to map every single case. There were 40 for family medicine. So yes. I just saw that comment. I'm glad it normalizes your struggle. And I mean, honestly, think about it. Are there any other struggles? Like, you have a great group of people here outside of me. Again, utilize all these resources that you have. If there are any challenges, I love talking through challenges. I see Susie. Hi, Susie, who we work together a lot and definitely help each other. She helps me a lot, certainly, in talking about our struggles.
Hey, Kristen, this was such a great presentation. I invited some of our faculty. Jeff Beeler is here from FIU as well. We were texting about how this was like, yes, we're right here with you. So I guess another way of saying it normalizes our struggles.
Yeah. Thank you, Susie. Okay, so question about using SIM. How do you find the faculty to staff it? Excellent question. It is a challenge. And honestly, what we do is we use residents a lot. And so our department did did say that they would not penalize faculty who missed clinic to come and help us. And so, because that's what we said, I mean, when we changed our model of funding, called the fund flow model a few years ago, it really changed time for education in a big way. And so I met with our department chair, who said, yes, education is important. We will not penalize people who miss their clinics to come help you with your simulations. But in addition, our residents are a huge help and make a world of difference. And then, okay, do we use pass fail or graded? So we just changed this a couple of years ago. We used to be honors pass fail. We're now honors high pass fail. So that's our current method. And I would be curious how many other people actually use pass fail versus having the range. I will say that part of the reason we did that was, so I was a huge advocate of step one going pass fail. But I shouldn't say but at the same time, what we realized is that was going to make it more difficult for program directors as they were trying to decide who to interview. And so it was decided amongst our faculty that we thought it would be beneficial to further kind of stratify students. Oh, interesting. Okay. So we see a lot of people, okay, or a few people, I should say, have said they do pass fail honors, and it's hard to distinguish honors. It is hard. And I will say, when we decided we were going to do high pass, I mean, I was like, oh my gosh, are we really doing this? But I did see the benefit. I saw the overall benefit of it in helping our students, hopefully, as we're trying to distinguish them throughout or in preparation for residency. But it is really hard, to make sure that you have clear guidelines. And for us, we actually changed our grading rubric so that it was very, again, competency or EPA based. So it was actual like activities, and it went away from, oh, they're really engaged. They like to be here. They like to this, but it's like, no, what are their skills in interviewing a patient? What are their skills in their physical exam and creating an assessment and a plan and that kind of thing. Okay. So there's a challenge of, reduced student exposure. That is so true. So we were lucky in that as our particular clerkship, we were able to come out of, once we got into 2020, academic year 2020, 2021, right? So July 2020 and moving forward, we were able to get our students back into clinical spaces relatively quickly. But that was not true for all clerkships. So for example, there were some that were utilizing a rehab center that was not allowing students to come back in. And that became a huge challenge because that's where they were meeting a lot of their objectives and having some of those clinical experiences. So that's where our alternative mechanisms became key. So again, that simulation, the standardized patient encounters really became important. And I think at this point, we've been able to move all clerkships out of that realm, but it was, again, really important. And Aquifer has a lot of resources. So I mentioned for family medicine, we use them, but I know some of our other clerkships, pediatrics, et cetera, use them as well. Okay, so how do we manage curriculum with the simulation curriculum, being that we have a distributed model? We do everything up front. So we keep our students here on campus for the first 3 days. And we have the longish days of doing all of our workshops, didactics that we need to get done before they go. And then when we leave, or when the students kind of disperse, we do have small groups, we have modules and things that they do. And so pre-pandemic, we were already doing this virtual, learning. It was already part of our routine. And so we were able to do a lot of things by continuing that kind of like flipped model. You do some work ahead of time, we meet together in a virtual small group. Okay. Oh, so other people in peds, using Aquifer cases a lot. That's awesome. And then could you remind us of what an aquifer in your setting means? Oh, thank you, Gary. So Aquifer is an organization that creates cases that are specific to a field, and students can go through. They're very interactive. There are free text questions, there are multiple choice questions, and the goal is to kind of like think about next steps and managing the patient. They're relatively long. So I always tell our students, like, expect that you're going to spend, 45 minutes on each one. But some students love them because that's how they learn. And some students are like, oh, I don't know, but they have great content, which is why we really love them. And as was mentioned in here, there is an exam too. Ooh, I like that question. We have not. Has anybody used Aquifer cases as part of your OSCE assessment? So objective structured clinical exam. And feel free to unmute. You can type in the chat or unmute. That is a good question. I will say I guess that would be kind of like, what is it? Script concordance testing, essentially, where you have an idea of what should happen in the case that people agree upon, and then you'd have them go through and make sure the students do kind of the right things. So we do not, but that would make sense. I would say the thing that, is a little bit challenging with it, and not a negative thing, but at one point, Aquifer used to give us ratings. And so before it was called Aquifer, they used to give us ratings, and we would get a red, yellow, or green, kind of to talk about the level of engagement, I guess, the student had with the case. We don't get that kind of information anymore. So I'm not sure how you would utilize it, but it's a good idea.
Mary, we can't hear you.
Sorry, is that better?
Yep.
Yes.
I was asking for permission. That's all I said. Is it okay if I just interject about Aquifer?
Yes.
In 2023, they're going to be changing a little bit, right? Where they're going to offer, it's a little bit how we're doing now our like MOCA, where you'll get short Quizlets instead of the long test at the end. You'll get short Quizlets to sort of reflect the way people are maintaining their certification now, instead of having a large board exam, which is very exciting. So we're kind of holding on to Aquifer for that change coming up the pipeline. So if anybody doesn't utilize it, now's a good time to sort of take a look at it and peek at it, because I think they're about to evolve into a very user-friendly testing modality. Sorry, that's my only plug. I make no money off of Aquifer. I just like it.
So I think we have utilized Aquifer a lot, and we've changed again how we use it. And so when I mentioned, I think I mentioned that we use a formative assessment for knowledge. It's the Aquifer exam. So we use that as our formative assessment that helps us inform students how to study for their MBME.
Great.
Hi, this is Jason. Full disclosure, I am actively involved with Aquifer.
Hey, Jason.
Hi. We will be pilot testing these questions starting 2022, next year. So if you are interested in learning about what we're doing with our questions that would be more formative, you would give it like mid-clerkship, and then you get feedback. The student gets feedback and clerkship director gets feedback. So we will be looking for pilot test sites for family medicine, internal medicine, pediatrics, geriatrics, radiology. I might be missing another one.
So Jason, there's a question: how do people get on that pilot?
If you are already using Aquifer, then go through your Aquifer contacts to reach Aquifer. Otherwise, you can Google Aquifer and send us an email, and we'll get you connected to the right people for the right disciplines.
Wonderful, thank you. So
with that, we're going to have to wrap this up. So thank you again, Kristen, for the session. I am off tomorrow, but Friday I'm planning on getting the recording up and ready to go on our YouTube channel, and I will be emailing everybody to let you know when it's available.
Thank you everybody for coming.
Thank you, everyone.